Hello, so today we are going to be talking about Surgery Background Chronicles 1. So let's start. So on intro, some of the things you have to know. Okay, now arteriovenous ulcers, the differences between arterial versus venous ulcers. So in these tutorials, so we are going to talk about things which I usually discuss on the ward rounds, and of course things you may not have gone through whilst you are studying your normal topics, because other things you may just find you're being asked and you have done the whole topics. Okay, so you need to know the difference between venous and arterial ulcers. The ulcer description. So what are the 5S of 5? The 5Fs of ulcer description. So we have surroundings, shape, size, site, surface, and size. So the thing is, I'm going to be giving some of the things like a revision. I'm going to be commenting on some of the things, then other things I won't be commenting on. I'll just be giving the questions. Okay, then principles of cannulation. Coombs test, you need to know what Coombs test, the types, and what condition is it used for. And then the brown specific bottle, as in the brown bottle is specific for what. Where can you use the brown bottle? Then intraosseous cannulation, you need to know what it is, where it's done, and also venous cut down, you need to know what it is and how to do it. Most likely, you need to know it. Then that's for best fluid of use in head injury. So of course, it's mannitol. That's the best fluid you can use in head injury. Then causes of failure when reducing paraphimosis. What are some of the causes of failure when reducing paraphimosis? And also types of reduction of paraphimosis. Okay, so these are some of the things I wanted to talk about. So the differences between arterial and venous ulcers. So the other thing is, let me go to the next one. Okay, you can pause this one and try to go through it, as you know the difference between arterial versus venous ulcers. Okay, so this is what I want to talk about. Okay, so uh, on definition, the difference one difference on definition is that arterial ulcers are due to ischemia. That's arterial ulcers. Then venous ulcers are due to stagnation of blood under pressure. Then location. Arterial ulcers can occur on weight bearing points. That's the location. That's the arterial ulcers. And then venous ulcers occur on the middle side of the leg. And then in terms of bleeding, arterial ulcers do not bleed profusely. Then venous ulcers bleed profusely. Then pain. Arterial ulcers are painless due to associated neuropathy. Then venous ulcers are painful. So at least this add some easy things you can understand. Then there's also this one which had a lot of data, but you can just pause and go through, because I've already exhausted most of the things in the previous one. Okay, so sutures. So we are now on a patient with sutures, since this is things you may be asked on a patient with sutures. And what happens if suturing is too tight or too loose? That's one. 2. How does suture granuloma look like? 3. Jenkins rule. So what's Jenkins rule? So Jenkins rule states that the amount of suture should be at least 4 times the strength of a wound. So that's Jenkins rule. Then seroma. A seroma is an accumulation of fluid beneath suture. So when there is accumulation of fluid beneath the suture or surgical incision, that's called a seroma. Okay. Then if you leave a suture in place, what happens? So of course, when a suture is left in place, there will be scarring, which will leave skin marks, and it may even cause permanent scar, which can lead at some point to a keloid formation. Okay. Then the last part on sutures, we have principles of suturing. Okay. Then we are now on IO, intestinal obstruction. So what is the 369 rule? 9 rule in intestinal obstruction. So the 369 rules just shows you diameter calibers of bowels. So we start from the small bowels. They should be 3 centimeters, and if they are more than 3 centimeters, they are dilated. And then the large bowels should be 6 centimeters. If they are more than that, then they are dilated. And then the appendix should be 6 millimeters. If it's more than that, it's inflamed. And then the cecum is the one which is 9 centimeters, and if it's more than 9, then it's dilated. That's the 369 rule, which will help you know the normal calibers of the bowels. They now do differentiate small bowel and large bowel from excess. So you know that small bowel, they are small bowel are centrally located. They have cannula veniventus. Then large bowels have ostrations. Then large bowels are peripherally located. Then of course, those are not the only things which you can use to differentiate. I think there are about 5 things you can use. I've only talked about 2 things: the location and their features. That's the only thing I've talked about. Okay. The next, the signs of sigmoid volvulus. Of course, they have the famous cough bean sign, but that's the only thing. So you need to know other signs that are there. Then length of rectum. You need to know the length of the rectum. Okay. And then blood supply. So we have such questions which come like, what's the blood supply to the distal 1/3 of the transverse colon? So those are some of the things which you are asked. So what's the blood supply to the distal 1/3 of the transverse colon? So you need to know the blood supply of the entire GI. Okay. Then how to check for viability of bowels. So of course, friability, breathing from the mesentery, and other things. So you need to know the color. There are a lot of things you can use to check for viability of bowels. So you need to look that up. Then management principles of IO, you need to know. Okay. Gutland supracondyle classification. I think this is the easiest everyone know in surgery. We have Gutland 1, 2, 3, Gutland 1 for undisplaced, Gutland 2 for partial displaced, and then Gutland 3 for completely displaced. And of course, there is modified Gutland, so you need to look up modified. Then traction, you need to know what traction is, the types of traction. And if we go to skin traction, you need to know the advantages, indications. You need to know everything. Then CT scan indication in head injury. So what are some of the indications of CT scan when someone presents with head injury? So we have GCS less than 13. Signs of basal skull fractures. So signs of basal skull fractures are raccoon eyes, which is just bruising around the eyes. Then which looks like, of course, they are black periorbital black, just say black eyes, but there's periorbital blackness. And then the other sign you can see is Bartol's sign, which is bruising of the mastoid process of the temporal bone. Then the other thing is cerebral fluid rhinorrhea and otorrhea, hemotympanum. Then the other indication for CT scan is deteriorating GCS. Then others, we have penetrating head injury. Then if a patient presents with focal neurological deficit, that's an indication for CT scan in head injury. Then hernia, there is differences between strangulated and incarcerated hernia. So one of them is strangulated hernia. The diagnosis is made clinical intraoperatively. Then clinically, you have to say incarcerated hernia. So when you're making a diagnosis of strangulated hernia, you do that intraoperatively, but clinically just say incarcerated hernia. Okay, so these are the indications for CT scan. So the ones I didn't talk about are suspected or depressed fracture, any sign of basal skull fracture. I think I talked about this. Post traumatic seizures, Okay, even vomiting, persistent vomiting, I didn't talk about this. So those are some of the indications of CT scan in head injury. Okay, then we go to penetrated chest trauma. Let's say on a patient with a penetrated chest trauma on the left side. So sucking chest wound management. So what's the management of a sucking chest wound? So of course we have to put a valve on partial occlusive patch. And for those who have come across the sucking chest wound, you have to know that in open pneumothorax, the patient may develop what they call a sucking chest wound. So that's in open pneumothorax. Okay. Then you have to put a partial occlusive patch. So since we don't actually have the original partial occlusive patch, you need to know how to put. So of course you have to look for a plastic or open drip. Specifically, you can just use the one for normal saline, the plastic ones, or a ring bag if it's available. Then you make a square, then use strapping, and that's if they are unavailable and you want to improvise, like in our setup, which we usually do to make a partial occlusive patch. That's how we do it. And you have to make sure the strapping is only covering on three parts of the square and leaving one part open, so that when you breathe in, it won't allow air to go outside. It won't allow air to go inside, but when you breathe out, it allow air to go outside. Okay. Then how to know if drain is working? So of course, an ICD, when you put, you have to know how to know. You have to look at the swinging meniscus, then it's working. Then precautions when removing drain. So you have to do a chest X-ray before and after. Then the other thing is this is another patient for peritonitis. You have to know what peritonitis is, the types and management. Then this is a tip. So in dead wounds, we do interrupted suture. Then clean wounds, we do continuous suture. So someone comes with peritonitis, let's say, then they are deemed to have, the dead wound, so to speak. So of course we can't do a continuous suture, so we have to do interrupted so that it's easier for us to go back in case of anything. Okay, that's how we do it. Then indications for continuous versus interrupted suture, I have to know the indications. Then advantages and disadvantages of continuous and interrupted suturing, you have to know. Alvarado score and this interpretation, you have to know. So Alvarado score, bearing in mind you have the mnemonic mantrails, where we have migrating right iliac fossa pain, you have anorexia, you have nausea, vomiting, you have tenderness in the right iliac fossa, we have rebound tenderness, we have elevated temperature, leukocytosis, and shift of WBCs. That's mantras, and you need to know what the interpretation. Like if you get a score of 5, what does it mean? If you get a score within 6 to 7, what does it mean? So that's the interpretation now. So you need to know the ranges. Okay. Then the other thing is paralytic areas. So this is a tip. So paralytic areas on X-ray as gas up to rectum, but in mechanical obstruction there is no gas in rectum. So this is how we differentiate paralytic areas and mechanical obstruction on an X-ray. So paralytic areas shows you gas up to rectum. Then in mechanical obstruction there is no gas in the rectum. Okay. Then we are now on amputation. So some of the things you need to know on amputation is, why does the amputee have short life expectancy? So this is mostly due to depression and CVD due to damage of the blood vessels. Then ulcers associated with amputation. So we have Douglas ulcer, that's an ulcer which is associated with amputation. Then spar. So what is bone spar? The definition for a bone spar. So this is bone formation that grow and can even pierce through the stump. So it's more like an abnormal growth, an abnormal bone formation that grow and can even pierce through the stump. Then major causes. So on here, the other thing you can be asked is what are some of the complications of amputation that can be associated with a bone? So what are some of the complications of amputation associated with a bone? So apart from bone spar, what other complications are associated with a bone? Then we have major causes of diabetic foot what are some of the major causes of diabetic foot? So apart from diabetic microangiopathy and neuropathy, so what are some of the major causes? Then we have Texas classification of diabetic foot. Then we have 5 key things to pass on to the amputee on discharge. So what are some of the 5 key things you can discharge on to the amputee on discharge? So make sure you write somewhere where you need to look these things up which are being asked here. Then why do we retract nerves when doing amputation? So of course we are going to prevent a neuroma. Okay. Complications associated with flap. So what are some of the complications associated with flap? So we have infection, wound dehiscency, necrosis, gangrene, ischemia, hemorrhage. So that's some of the complications associated with flap. Then why septicemia is important to consider in amputation? So that's a question for you to know. Then this is an diabetic ulcer. So let's go through diabetic ulcer. So causes, we have increased glucose in tissue which precipitates infection. We have diabetic microangiopathy which affects microcirculation. We have increased glycosylated hemoglobin which decreases the oxygen dissociation. We also have I don't know why Texas classification wants us to go through it. Okay, we are back. So we also have increased glycosylated tissue protein which decreases the oxygen utilization. We have diabetic neuropathy which involves all sensory, motor and autonomic components associated with atherosclerosis. And then some of the problems associated with diabetic ulcer are we have neuropathy. You can have in-foot clothing of toes, hammer toe due to intrinsic muscular paralysis. Then we can have multiple deeper abscesses, osteomyelitis of deeper bones are common. You can also have reduced leukocyte function, resistant infection. Okay, then the other thing is arterial insufficiency, septicemia, diabetic ketoacidosis, associated cardiac diseases like ischemic heart disease. Then so how do you treat diabetic disease, diabetic ulcer? So you can control diabetes using insulin, of course, depending on the type. And then the other thing is you have to give your antibiotics since you talked of infection, precipitating infection. Then you have nutritional support, regular cleaning, debridement, dressing, and once it's granulates, the ulcer is covered with skin graft or flap. Then we have toe or foot leg amputation, of course, depending on how the prognosis is. Then microcellular rubber shoes to prevent injuries and care of foot. And of course, you have to make sure the patient is not usually wearing tight shoes, so that's a risk factor for having diabetic foot. So that's why we have on treatment we have microcellular rubber shoes, MCR. Okay, that's all. So this is Texas classification of diabetic foot ulcers. So we have stage A0, stage A, grade 1, grade 2, grade 3. So the one difficult thing is stage A. Then the other B, C, D, they have the same thing like infection, ischemia, infection, and ischemia. So we are just going to go through stage A. Then these other things are easy. So stage A, grade 0, we have pre or post ulcerative region completely epithelialized. Then we have grade 1, stage A or stage A, grade 1. We have superficial ulcer not involving tendon, capsule, or bone. Then we have grade 2, stage A, ulcer penetrating tendon or capsule. Then we have grade 3, stage A, ulcer penetrating to bone or joint. Then stage B, grade 0, 1, 2, 3, they all just have the same things, ulcers with infection. Then stage C, grade 0, 1, 2, 3, ischemia. Then stage D, ischemia and infection. Okay, then this is Megid's classification of diabetic foot. We have grade 0 for foot symptoms like pain only. We have grade 1 for superficial ulcer, grade 2 for deep ulcers, grade 3 for ulcers with bone involvement, then grade 4 for forefoot gangrene, then grade 5 for full foot gangrene. Then we have Wagner's classification of ulcers in general. So this is ulcers in general. So we have grade 0 for pre-ulcerative region or ileal ulcer, then grade 1 for superficial ulcer, grade 2 for ulcer deep to subcutaneous tissue exposing soft tissues or bone. Then we have grade 3 for abscess formation underneath or osteomyelitis. Then grade 4 we have gangrene of part of the tissues, limb or foot. Then we have grade 5 for gangrene of entire one area of foot. That's Wagner's classification. Then gastroschisis and OMPHALOCELE, a patient on gastroschisis and OMPHALOCELE. Some of the things you need to know are: why is gastroschisis on the right side of the abdomen? So why is it on the right side of the abdomen? Then what is Beckwith-Wiedemann syndrome? Then between OMPHALOCELE and gastroschisis, which one is worse? So the answer is OMPHALOCELE is worse because it is associated with many syndromes. Then what is the difference between OMPHALOCELE and umbilical hernia? So OMPHALOCELE has a thin translucent membrane, whilst umbilical hernia is covered by skin. That's one of the differences between OMPHALOCELE and umbilical hernia. Then pentarology of Cantrell, we need to know what it is, most likely. Then the other question is, what conditions are associated with OMPHALOCELE? So we have cryptorchidism, polydactyly, then other things include trisomy 13. Then this is Beckwith-Wiedemann syndrome. So there is a triad in Beckwith-Wiedemann syndrome. The child has macroglossia, umbilical hernia, OMPHALOCELE. Then these are some of the growth abnormalities, such as the same things plus the same triad plus the same things which are here. Okay. Then this is pentarology of Cantrell, where we have OMPHALOCELE, anterior diaphragmatic hernia, sternal cleft, ectopia cardis, intracardiac defect. Okay. Then that's the end of the first round. So stay tuned for the next round, which is the last part for surgery ward round Chronicles. Thank you for watching.